So good afternoon and welcome to day 4 of the St. Luke's Kansas City Virtual Amyloidosis Symposium. I am Dr. Furha Cossor. I'm your moderator for this afternoon. I'm one of the hematologists here at St. Luke's, and I'm joined by 3 of my co-hosts along with our speakers. My co-hosts are my colleague in the hematology department, Dr. Shahzad Raza, as well as Dr. Brett Sperry and Dr. Ibrahim Saeed. They are our friends here in the cardiology division, and they work at the St. Luke's Mid-America Heart Institute. On behalf of all of us, I'd like to welcome the participants, welcome our speakers for today, Dr. Dispenzieri, Dr. Comenzo, and Dr. Witteles. So today we're going to be discussing relapsed amyloidosis and management of cardiac complications in the various types of amyloidosis. But again, as you may have heard before we started, we were gonna just put through some housekeeping things. So first of all, we're gonna try and keep our speakers to their allotted time sections so you guys can have time to answer or ask questions. They might ask you questions you can answer in the chat box to the side. And again, if any participants have questions, we do ask that maybe you send the question to everyone, because then it will be recorded. And if we don't get to your questions, we can pull them up and certainly send them to the appropriate speaker later. And if any of the speakers finish early, we can add in questions at the end of their section. If not, we'll save questions to the end for the Q&A and case-based discussion between 3:30 and 4. So with that, I'd like to introduce our first speaker, Dr. Angela Dispenzieri. Dr. Dispenzieri is
over there.
Oh. Dr. Dispenzieri is the chair of hematology research at
You're muted.
Am I?
You muted yourself too.
You're muted now, yeah.
Okay, am I muted?
No, you're good now.
Oh, okay, all right.
So start over with your introduction, please.
Oh, okay, all right.
No, you're good.
Okay. So
We'll crop this part out of the video. So Dr. Dispenzieri, despite being not as technologically, no, I'm just kidding.
Hey, I didn't mute everybody.
I know, I don't know if I did that. I have no idea. I'm also not technologically advanced, so that's why we have Becca. But you are the chair of the hematology research at the Mayo Clinic in Rochester. You are a world-renowned expert in AL amyloidosis. She has been widely published in the field of AL amyloidosis, multiple myeloma, and other plasma cell dyscrasias. To say that is an understatement, as evidenced by her 133-page CV that she sent me. So she has had numerous NCI-funded grants. She is the expert that experts look to for advice in this field, and we are very honored and very humbled that you agreed to speak with us today. So she'll be talking about response criteria, maintenance therapy, and relapse in AL amyloid.
Okay, well, thank you for that very, very kind introduction. You can see my screen, I suppose. Good. Okay, so we're going to talk AL amyloidosis response criteria, maintenance therapy, and relapse. Please forgive me in advance if some things are a little too basic, but I expected a mixed audience, not all hematologists, so hematologists may get bored in spots, but sorry. But let's move forward here. So just as a refresher and a reminder, and you've seen this over the course of the past few days, we know that AL amyloid is a disease of monoclonal plasma cells. These plasma cells make these free light chains, and then in turn, amyloid fibrils are made that are causing tissue damage as well as eventual death if gone unchecked. And so when we think about monitoring these patients, we can directly measure things like the light chains, and we'll talk about the tests that we use there, and the plasma cells. But for the organ involvement, we really need to use indirect measures. There's some really interesting imaging agents that are kind of in research. They're not clinically available, and that may change it. But for now, all of the tissue damage measurements are pretty much surrogate measures. So again, when you have a new patient, the treatment goals, looking at it in a very simplistic way, you're going to stage the disease, assess organ involvement to start with, and then you're going to think about plasma cell-directed therapy. And you've heard a lot about that already yesterday, and you'll hear more when Ray speaks. And the goal there is something called hematologic very good partial response. When we do plasma cell-directed therapy, always clinical trials are preferred, but we're aiming for a heme VGPR or better, and we'll talk more about that as we go on. We really like CR better, but there are pluses and minuses in making that decision. And then if there isn't a hematologic very good partial response, then we're going to think in most cases about consolidation and potentially even some kind of a maintenance. In terms of the patients who do get a hematologic very good partial response, we're going to think in terms of observation. And in some instances, we may still want to give more therapy, and we'll talk about that later. But first, I'd like to talk a little bit about what the response criteria are and what they're comprised of. And so in terms of the 2012 consensus published by Ray, we have essentially complete response, which is defined by a serum and urine negative by immunofixation, a normal involved free light chain, and a normal free light chain ratio. And a very good partial response is basically having the difference between the involved and uninvolved free light chain being less than 40 mg per liter. And a partial response is considered measurable or assessable if the involved free light chain is more than 100 mg per liter or 10 mg per deciliter, and you get a 50% reduction. And so this is how we grade our hematologic responses in the present day. It should be noted that in complete response, at this point, there's no requirement for a bone marrow biopsy. So kind of just doing a little bit with immunoglobulins 101 here. The free light chain is the quintessentially important test when it comes to following patients with AL amyloidosis. And again, you've seen, you all know, an immunoglobulin, an intact immunoglobulin is 2 heavy chains and 2 light chains. They're also in normal people, but more so in patients with AL amyloid, we have circulating free light chains, so light chains that are not bound to heavy chains. And so this reagent, and there are other reagents coming on the market as well, recognize these sort of hidden epitopes that are only seen when the light chains are circulating on their own. And this is a nephelometric test, so you just kind of, put it in the machine, it does dilutions, it's light scatter, and you get a number. The other tests that are used, less important in AL, is the serum protein electrophoresis. And the level of detection there is not great. And so for the majority of AL patients, this protein electrophoresis, where you put a little sample, little serum here, and then run it by charge and mass, it sort of goes across and you get the multiple fractions. And here, this is more of an example of a myeloma patient, a nice big spike here in the gamma fraction. Again, for the majority of patients with AL, this test is not going to be particularly informative, and the level of detection is about 0.5 grams per liter. A lot of these levels of detections that I'm going to quote to you here are very approximate. It depends on what the polyclonal background is. In a very hypogamma patient, you're going to get a better level of detection of your monoclonal protein, but it's just to give you an idea. Then there's the immunofixation type of test, and the level of detection is about an order of magnitude better. And again, this is a qualitative test, however. So here's the protein electrophoresis that's basically kind of serving almost as markers here. We don't typically quantitate off of this SPEP. We sort of run it separately with different dye. But here you can see that you have antibodies directed against immunoglobulin G, immunoglobulin A, immunoglobulin M, kappa, and lambda. And you put sample in each of these wells. And if there is a monoclonal G, you're going to get this precipitation here, and you're going to see the monoclonal protein. So this is a G lambda patient. And this is a helpful, and this is important in response, that's part of CR, that this should be a negative test. Sort of new technology is using mass spectrometry, and this particular assay is essentially similar to the immunofix in that there's where you break it out. There are, for each patient, 5 wells. One has a camelid against IgG, one against A, one against M, and then also kappa and lambda. And in this picture, the turquoise is representing the heavy chain this is all one patient, but the turquoise is the different heavy chain reaction. And then the blue is lambda and the pink is kappa. And the kappa and lambda are run in each of these. And so here you can see this patient is a G lambda because we have turquoise and blue there. And here we just see the lambda, but no associated heavy chain. And the level of detection here is like another order of magnitude better. And then we also can do by liquid chromatography, mass spectrometry, electron spray, which is at least an order of magnitude 5 times better than the MALDI, and maybe even 10 times better, but you can just see a nice spike as you dilute things down. And so these are ways that are currently part of the response criteria, but they may eventually prove to be. Again, plasma cells 101, we mentioned that it's not currently part of the response criteria, but revisions are in progress. People are talking that these plasma cells are definitely something that are going to be important as we rethink of response. And here you see monoclonal plasma cells. These are the only living piece here aside from the person itself. You know, these are all proteins. This is stuff that we can kill, and that's what we direct chemotherapy at. And then in theory, this will go down and this will go down and patients get better. But in terms of the bone marrow, so it was a great idea to exclude it from the response criteria because, again, it's invasive, not terribly so, but invasive. And you couldn't code patients for complete response if they didn't have a bone marrow. And the thinking is, well, the circulating thing is the light chain anyway. And if you don't have a lot of light chain, then you shouldn't have amyloid. And so the bone marrow should really correlate with that, and it shouldn't matter as much. That's proving to not necessarily be the case. And so with advancing technology, this is going to change moving forward. And so this is just a series of patients. This is only 6-color flow. I'll show you data on higher sensitivity flow, but it gets to the point that if you have patients that are coded to be in CR, the amyloid CR with the negative fix, the normal free light chains, the progression-free survival of those who have no monoclonal plasma cells in their bone marrow detected by flow do much better in terms of PFS than those who have existing plasma cells. In this study, though, with this level of sensitivity, the survival difference was not different, you know, going out at 8 years. Now, others have looked at higher resolution flow cytometry, and what this is from Boston data. And what you can see here, the red bars are those patients who basically by flow, the bone marrow cannot detect minimal residual disease in red, and the blue saying that although they look like they should be in complete response, when you do the higher sensitivity flow, it's still positive. And what you see is renal response, so the percentage of patients that have a renal response here on the left. And you see that there's definitely a trend for more patients achieving a renal response amongst those who have a deeper bone marrow response as compared to those that still are weakly positive, even though the blood and the urine look quite good from the standpoint of the monoclonal proteins. And here, cardiac, again, it's very underpowered, so there's no statistical difference at all between it, but you definitely get a sense that maybe there's something going on there. And similarly here, you can also see any organ response. Again, small sample size, so not the power to detect, but I think we are going to see more. We did a similar kind of study. We didn't have as pretty a picture, so I didn't bother plotting it out. But again, the same trend is that there's a likelihood of having a deeper response for those patients that are MRD negative. And then this is using a higher sensitivity flow, again, with patients who are in at least a very good partial response or complete response. And if the bone marrow is truly negative by flow, that's 10 to the minus, detecting 1 in 100,000 plasma cells. If you don't detect any, the progression-free survival is superior to those who are positive. However, and also if you limit this to just patients who are in complete response, it's a similar outcome, but yet also not a survival benefit documented. Again, you'll notice that survival even here, or progression-free survival, we're looking at 5-year rates of 75% progression-free in these patients who have a negative bone marrow. So you can imagine that you might need to follow patients for 10, 15 years before you would see an overall survival benefit. So getting back to hematologic response, again, the whole idea of focusing on the free light chain was born out of this work by Giovanni Palladini. And so this blue line is that complete response, immunofix negative, free light chains normal. This is a very good partial response. The first time we really included the free light chain as a single measure to get us to a response category called very good partial response, which we've had in myeloma for many years, more than a decade or so. And then this partial response, and then patients with no response. And so this is at 6 months, patients who are assessed, and at 3 years, markedly different overall survival based on the complete response. And so these are the consensus criteria that I showed you earlier. It had evolved from the 2004 consensus criteria, showing that it's 8 years later, we're due for another consensus. But what had changed is the bone marrow was taken out. I suspect we'll end up adding that back in, but the DFLC being in there is important. And then for partial response, the M spike was really deemed not to be that relevant. And I don't think that's something that really needs to change. But we're definitely due for a revision. But when we think about organ response, again, this is where we talked about the indirect measures. And this is what we really care the most about, because a patient doesn't have any awareness that they have increased number of plasma cells. They have 5% or 10% plasma cells in their bone marrow. There's no sensation there. However, when you have amyloid in your heart or your kidneys or your nerves or your liver, there is a sensation. And so that tissue damage is what we really care the most about. And so there are a number of different surrogates that have come up to help us understand how patients are doing. And so the predictors for organ response in AL really relies on a lot of different things. One is the severity of organ dysfunction at baseline. So one of my colleagues, Eli Muchtar, he basically shows like a ticking time bomb, when he gives a talk, because the reality is when you have a patient with AL, it's a race of getting a hematologic response before the patient may succumb to their dysfunction, their organ dysfunction. So the later a patient is diagnosed, if they have severe cardiomyopathy, it may be a point of no return. And so no matter how good a hematologic response they get, they could still suffer from sudden death. And so that has a huge impact. You can't have an organ response if you don't survive to have an organ response, and if you don't have a hematologic response. Another predictor of response is time. So again, amyloid, you can measure the light change, you can measure the bone marrow plasma cells virtually in real time. You can look at things even at a week or 2 weeks, a month, two months, and you see that there's an improvement and a reduction. But the amyloid, the organ dysfunction takes months and months to improve. And so if you look too early, you could be fooled in saying, oh, this isn't working. You know, even though the patient has a hematologic response, you know, their heart still doesn't look good, and, you know, they still have signs of congestive heart failure. Well, you have to be patient in this business in terms of waiting. If you're getting a good heme response, you have to give them supportive care for their organ dysfunction, but you have to think about time. And then, of course, we'll talk about the bulk of underlying plasma cell disorder that does affect organ response and heme response. And then, of course, the depth of the hematologic response will predict for organ response. And I showed you even the MRD status can potentially affect organ response. And so here are patients that have, you know, Mayo 2004 stage 3B patients. Median survival of this population is only 6 months. But the UK group showed that if you get a hematologic response in these very, very sick patients, there's a dramatic difference in overall survival. And so here you have patients that get a CR or a very good partial response with a median survival of, it's not a lot to brag about, 3 years, but again, it's far better than that 6-month survival. And again, the point of this paper was that if you do it quickly, patients do fare better than if you don't do it quickly. And so that's where you've heard, I'm sure, yesterday about the importance of getting highly effective chemotherapy into patients that are very sick. Now, here is organ involvement and response, and this is very, very busy, and I'm going to summarize it, but the first part is, these are the 3 most important organs, and they're the ones that we can actually track to some degree. We have kidney involvement, which is mostly a function of the urine protein, heart, which is defined, you know, by echo, alkaline phosphatase, and liver size for liver. And then we have various degrees of improvement for kidney. It's urine protein reduction and changes in creatinine clearance, and worsening is similar, kind of in the other direction. Heart, it focuses on the NT-proBNP and New York Heart Class. And again, the progression includes troponin as well. And then liver is focusing on the alk phos and liver size by imaging. We have a number of other organs that are potentially involved, and we have definitions of how we call them being involved, but we don't actually have response criteria for things like nerve, or good response criteria for peripheral nerve, autonomic nerve, GI, lung, soft tissue. The involvement of each of these organs in a symptomatic way is pretty unusual, or, you know, kind of, we're talking in the 15% range for here and less for these other 2 areas. Soft tissue is higher, but again, it's not life-threatening and less important to really measure. But it's complicated, and you know, you kind of think, God, I'm glad well, sometimes I wish I wasn't a hematologist. It's hard to really figure out and sort through. But again, we talked about the NT-proBNP, and these are the change in NT-proBNP. So those patients who get a 30% decrease in their NT-proBNP will have a 3-year survival of 85%, in contrast to those who have a 30% increase in their NT-proBNP, who have a survival of only 20%. And then here you have those patients who are sort of stable in between. And so this is an important focus of response, but it is also a limitation because we know that NT-proBNP can be something that can fluctuate. A patient can be doing very well, but they have, a fancy dinner with a lot of salt in it, and all of a sudden, their NT-proBNP can worsen significantly. But the thing with time to maximal organ response, I mentioned organ response is time dependent. And so this is from Ellie from our institution, Dr. Muchtar, where it's showing us several things. So each of these graphs, this is cardiac is A, B is renal, and C is liver. And what you have on the y-axis is the proportion of patients evaluable for response that are getting that response. And so the green lines are the deepest responses. And so the current organ response is really, did you have some response, yes or no, or did you worsen? But it doesn't give a gradation like we do for hematologic response. So he basically did the exercise of looking at degrees of response and the time scale in which patients would achieve that. And so here you can see patients at that a small fraction of patients with cardiac disease, only about 20% or so will get, you know, like a normalization or a 90% improvement in their NT-proBNP at, say, 6 years here. Whereas a higher percentage, almost 60%, will have a 60% reduction in their NT-proBNP, and nearly 80% will have a 30% reduction in their NT-proBNP. And this is currently, this is the partial response. Here's the renal patients, and again, you'll note that it takes a long time to get even a 30% reduction. So here it's at 4 years, you have patients, you know, not everybody who's gonna yet to respond is gonna respond. And so the name of the game, if you get a deep hematologic response, you sit back and you watch and keep your fingers crossed, especially if you have a complete response. You really, and it's MRD negative, giving somebody additional chemotherapy is really just giving them toxicity, unless you're doing it for the purpose of maintenance, which we'll talk about in a little bit. And here's a similar exercise for liver. And then this is overall survival. And again, the degree of NT-proBNP improvement does parlay into different overall survivals. And for renal, again, it's kind of the 30% versus really 60% or better. And the same thing for the liver patients. Again, this is not something that's universally accepted. It's something that others will, you know, potentially decide whether they want to validate it and so on. But I think it does have potential. But moving to progression or relapse, I would say that this is probably our weakest link in amyloid. This is the definition of hematologic progression, and it's progression from complete response, which you might call relapse. So the definition there is any detectable monoclonal protein or an abnormal free light chain ratio. And then there is no defined progression criteria from VGPR, so you kind of use the PR definition. And so it's either a rise on the serum protein electrophoresis, M spike, which is pretty unusual, or a rise in the urine protein electrophoresis, M spike, which is also not as common, or a 50% increase in the free light chain to at least 100 mg per liter or 10 mg per deciliter. And the reason I say that this is our weakest link is that there is tremendous ambivalence about waiting for a progression event, and that challenges trials. So if you take somebody, because you're saying, I'm not waiting until my patient gets to 10, I'm worried, you know, that they're going to get sick, then they get censored. They never meet progression, and so you don't have an event. And if your trial was powered for, you know, this many progressions, you end up with a big fat nothing because everybody's censored. And so that's a major challenge. The other interesting piece is that there are patients who have free light chains that are even at diagnosis that are very low. They're 50 mg per liter or 5 mg per deciliter, and these patients overall have a better prognosis, but they're hard to assess for response. And so Palladini basically has come up with this concept of high-risk DFLC progression as meeting multiple complicated criteria. Basically, the DFLC has to be at least 20 mg per liter at the time of progression, but it also, the DFLC has to be more than 20% of what the baseline value was, and the DFLC has to be at least 50% higher than the nadir DFLC achieved post-therapy. So that is a little on the complicated side. It works for patients who don't have very high baseline DFLC. So if you have a very high DFLC, this parameter is, second parameter is hard to achieve. And then organ progression and adverse events are often difficult to differentiate from each other. So I mentioned the salty meal. The NT-proBNP went up. Is that an AE? Or drugs make NT-proBNP go up, or it may make your alkaline phosphatase go up. So this is always a bit of a challenge. Other challenges with response, I mentioned this low DFLC at baseline issue. A proposal by a number of groups is that maybe you can get the goal DFLC of less than 10 mg per liter as a response criterion, so that we can have patients with less than, with a DFLC baseline of 20 to 50 and put them on trials and assess them. And that's going to be most handy in relapse patient trials because again, people have all different levels of free light chains at diagnosis, but people get very antsy when things start going up, especially if somebody had achieved a CR. And then the other part that I don't have time to address, and fortunately right now it's not a major issue, but I think it will be over time, is that there are alternate free light chain assays with different performance characteristics. So Siemens has an approved assay. The response, what's 50% with the binding site assay is 30% reduction with their assay. And so how we're going to get our heads around all of that is going to be a challenge. And Sabia has come up with their own free light chain, and they're bringing that for FDA approval. So those are problems for the future. But getting to consolidation and maintenance. And so back to this slide that I kind of went over in a cursory fashion. So this, if we focus on the bottom part of the slide, so we have this hematologic, very good partial response. And yes, CR is preferred, but I think, this is kind of derived from our MSMART algorithm. This is a hard one where we sort of cop out, at least in paper, in saying, we refer to an amyloid center in making some of these decisions, because in terms of, for a lot of patients, I mean, if you recall that survival, those survival curves amongst patients in VGPR, it wasn't that terribly different from the patients in CR. I mean, again, they're patients that you don't necessarily have to beat up that much, and there's no right answer there in terms of, what if you try to salvage somebody a little later, or you give them a little extra time, and are they getting their organ responses? It becomes a little bit of a philosophical question as much as a true medical question, but you always have to balance toxicity and benefit on paper. But the other really important piece that we'll talk about is this notion of consolidation and maintenance and who we do it in. And so one of the parameters is if patients are kind of myeloma looking, and most of the trials are written, excludes myeloma, and they refer to the presence of CRAB, having a high calcium, renal failure, anemia, or bone lesions. But the reality is that bone marrow plasma cell count is as important as these other features in terms of overall survival and prognosis. So again, the red and the green line, if you have over 20%, we had done a study earlier at 10%, again, you have higher bone marrow plasma cells and patients do less well. And here you have, here's the 10 to 19% plasma cells at baseline at diagnosis, here's 5 to 9%, and here's those patients with fewer than 5% plasma cells. And that alone is a very significant prognostic feature. And even on multivariate analysis, it is independent of just about everything and anything. And the reason is that these patients with 20% plasma cells, everything in red is typically a bad. The red are the patients who have the higher bone marrow plasma cell count, and you can see that the red patients are going to have more likely have cardiac involvement, high troponin, high NT-proBNP. They're also going to be more likely to have more myeloma-like features, and they're more likely to have high-risk cytogenetics and other bad features. And whereas the low bone marrow plasma cell patients are more likely to have proteinuria and be renal patients. And so they are a very particular kind of group of patient. And the more plasma cells, the lower the hematologic response rate, especially when you're looking at CRs. So again, baseline at diagnosis, if the plasma cells are 5%, about 40% of patients will end up in a complete hematologic response, 35%, or if it's fewer than 20%, but only 19% of patients who have greater than 20% plasma cells in their bone marrows are going to achieve a complete hematologic response with first-line therapy. And again, this translates whether you're looking to the right at stem cell transplant patients, you have, again, just not looking at response per se, but just looking at the overall plasma cell burden. Those patients with low burden do far better than the other patients. And this is true when you're also looking at patients who are too sick to go to transplant, your higher risk patients. And once you actually have a complete response, if you achieve that complete response in these patients with the higher plasma cell burden, you can see that they're still less likely to be alive at 8 years than patients who had a CR but started with a lower plasma cell burden. So when we make recommendations about consolidation and maintenance, we're entering a weak data zone. We can say that patients with these higher levels do worse. The question is, we don't have tons of data to really say, or even less than tons, pounds of data to say that doing something differently is going to really change their natural history, though the sense is probably that that is true. And so again, these are the patients where you might consider, if you have a more myeloma-like phenotype, you're more likely to then say, number one, if I didn't get a CR, I really want to consolidate them and try to get a CR. And these are also the patients that you're going to more likely want to use some type of maintenance therapy. And although there's not a lot of data, or there's like virtually no data with maintenance in amyloid, though there are data out of MSK. Ray had a lot to do with that, with consolidation in patients that had less than a CR, that can be an effective strategy. The concept maintenance has not been really studied in this population. And so the suggestion is to consider maintenance in these patients if they're really myeloma-like. If you have somebody with really bad cardiac disease, however, you know, getting Revlimid and keeping them on Revlimid may be very challenging because, again, the IMiDs can be challenging in cardiac patients. We do say that if you're going to consider doing some kind of maintenance strategy, just like in myeloma, where these high-risk cytogenetics or FISH, you may consider using a PI like Ixazomib or a different PI in that setting. But again, delicate balance, toxicity and response. And so in summary, hematologic response predicts for organ response, and both can be affected by a severity of organ involvement and plasma cell burden at baseline. The median time from treatment initiation to maximal organ improvement is about 2 to 3 years. And the median time to like a lesser reduction, like a 30% reduction, you can see 6 to 9 months. It's reasonable to consider consolidation maintenance therapy in patients with higher plasma cell burden and any high risk myeloma-like features, but we are sorely in need of new improved organ and heme response criteria. And with that, I'm more than happy to take questions. And I guess I stopped my share.
Yes.
Okay.
So,
I don't know how I am for time.
oh, you're fine. You're fine.
Okay.
We started a little bit beyond the 1:30 time, or the 1 o'clock my time, 2 o'clock everybody else's time, but I think because of that, I think we're going to move
Do
on to
questions later.
Dr. Comenzo's talk. But if you can stick around for that
Absolutely.
piece, we did get a few very good questions that we'll pose to you there at the end.
Great.
All right, Ray, if you want to go ahead and share your screen. I'll go ahead and introduce our second speaker. He is another heavy hitter in the field of AL amyloid, and this is the one and only Ray Comenzo. Dr. Comenzo is the founding director of the John C. Davis Myeloma and Amyloid Program at the Tufts Medical Center in Boston. He actually started his career at Boston City Hospital, did his HEMONC training at the New England Medical Center, and then honed his expertise in amyloid at Boston Medical Center, Memorial Sloan Kettering Hospital in New York, and then finally came back to Tufts Medical Center in 2008, where he has been since. He too is widely published and internationally recognized as a thought leader in the field of AL amyloidosis. And Ray, more on a somewhat personal note, I think what's notable about you is that you are a very good mentor and you have helped shape the careers of some of the other thought leaders in the field of amyloid and plasma cell dyscrasias. And I think that's really the mark of a true leader. So we are very, very honored that you could come and speak with us today. So he is going to talk to us about relapsed AL amyloidosis, treatment options, and novel therapies.
Furha, thank you very much. I am very impressed with what you folks at St. Luke's have done, putting this conference together. Kudos to Brett, his colleagues, and you, Furha, and to Rebecca, of course. And I want to thank Angela for a really wonderful, inspiring talk highlighting many of the problem areas that we face. This is the outline for my talk today. Relapsed AL, we know it when we see it, we think, but as Angela said, it's the weakest link. What are the options for treating relapsed AL and what therapies are in development? Let's start with a case. It's an actual case of a woman who was 65 and was diagnosed with AL shortly after her fraternal twin sister was diagnosed with myeloma. Ironically, the AL patient has outlived her twin. She had multi-organ amyloid at diagnosis. I treated her at that time with MDEX, which was ideal for that era. She achieved a complete response, had organ responses, had a maintained response for 5 years, and then began to show evidence of recurrent disease. The free light chains didn't increase that much. We were very fortunate at Memorial to have free light chain assays available to us from 2002. So I treated her with Bortez Dex. 8 cycles was what the regimen called for at that time. It was what the initial Velcade trials involved. Again, she achieved a complete response and was good for 5 years. When she relapsed, Hani treated her with Bortez Dex times 10 cycles. She achieved another response, but then got an infection. And the metapneumovirus infection appeared to really set her back. Her cardiac involvement appeared to increase. She had clonal disease in her marrow. Cardiac MRI was positive for late gadolinium enhancement. Honey tried a little Lendex because she had not received an IMiD at that point. She couldn't tolerate it. And then over a 3-year period, she got Darindex, 34 doses in toto. She achieved what we now call a modified CR. I'll mention the definition shortly. And her free light chain levels were below detectable limits. Her organ responses were restored. A truly remarkable story. And one that I think we've seen with some frequency, relapse from a deep response with both hematologic and organ progression underway at a rather low light chain level. But there are many questions. As Angela suggested, this is clearly the weakest link in our ability to care for patients. We did have criteria established as was described, and we did have new criteria for response and progression defined 8 and 6 years ago, but they were basically in newly diagnosed patients, making the design of clinical trials somewhat problematic in the relapse setting. In addition, a consensus has emerged that in patients who have suboptimal responses after an initial treatment of 2 cycles, perhaps 2 to 3 cycles, a change in therapy is indicated. And those folks we could call refractory disease. Certainly someone who relapses is treated as our patient was with Lendex and had progression, could be considered to have relapsed refractory disease. But these terms are a little spongy in AL. We also have some advice from experts. We have several series of cases. These are patient series relapsing after stem cell transplant, and another patient series relapsing after standard therapy with Meldex or Bortez-Meldex. And what you see are the features of the relapse, the numbers of cases in the series. The group in Italy has really emphasized DFLC changes, as was indicated. The BU group would wait until patients had organ progression. They didn't publish PFS or OS data in this blood advances paper, but their CR plus VGPR rate was about 40%, a little low. The Mayo group published the median overall survival of 4 years plus, and the group at Pavia identified the fact that they were treating patients early before organ progression occurred, and that was the case that has been made by that group. And their median overall survival is not bad. It's almost 5 years. So what do we do, however, with progressive organ dysfunction? What do we do with it? And this is a classic case. This man was 66 when he was diagnosed, had type 2 diabetes. He had a BMI of 43. We treated him. He was in a maintained CR, and then his proteinuria started to climb. And as his proteinuria started to climb, the slope of his eGFR declined. I actually think this is a very important aspect that has been unheralded in assessment of amyloid organ involvement. I think rather than being fixated on responses, which are extremely important and worth reporting, we should pay a lot more attention to the frequency of progression and the character of progression. We started treating him with daratumumab, and he did respond, even though his light chains were not that high. They were in the mid-30s. He has had a reduction in his light chains, but I got an email from his Rhode Island doctor yesterday. His eGFR remains 19. He's not on dialysis yet. So that's a problem area for us because certainly even with a VGPR, there may be some culprit light chain protein being produced. Well, what about hematologic progression from a VGPR? Well, this is kind of another interesting case. This man presented, he was 54. He presented with severe neuropathy that had resulted in massive weight loss and muscle loss. His BMI was 21 when he was diagnosed. We got him through a stem cell transplant. We're consolidating him with ixazomib Lendex, in part because he had 25% plasma cells in his marrow at diagnosis. He was doing really, really well, but was still on TPN, and then developed a line infection. So this wasn't a metapneumovirus infection, this was a bacteremia, and that set him off down on a downward course, again, the downward slope of eGFR. At that time, his light chains were not that bad, but as soon as they started to creep up in this range, we began him on daratumumab, and it has held him for the most part. He's obviously escaped as he has experienced worsening renal failure as free lambda has gone up. Fortunately, we were able to get him venetoclax which has made a big difference. He had the 1114 at diagnosis. I'll talk a little bit about that. But he is unfortunately now dialysis dependent, awaiting a renal transplant from a living related donor at a hospital in the Middle Atlantic area. What about rebiopsying these folks when they have organ progression? I have not found it to be a useful tool. It's the case that what you find is amyloid. The amyloid really doesn't go away, particularly in the kidneys. And we have never diagnosed an alternative cause. So I'm not a fan of rebiopsying unless there is a protocol that requires rebiopsying to confirm the continued presence of amyloid. And we did have such a protocol. Unfortunately, it closed when the anti-amyloid monoclonal NEOD-001 was stopped. But the idea of biopsying tissue and really studying the tissue with respect to appropriate molecular assays and appropriate pathologic studies is one that still attracts me greatly, even though there are many challenges there. So let's talk about treating relapse. Stem cell transplant. This is a list of items I'm going to talk about. The folks at BU evaluated a second stem cell transplant at a time of recurrent disease after the first one. And most of the patients did okay. There's a small number of patients. I think there were a couple of deaths within the first year after a second transplant due to progressive disease. But again, it was considered an option within the past decade. It's not the first choice now. We looked at stem cell transplant as a second-line therapy for patients who did poorly with Bortez, but were well enough to undergo at least a MEL-140 transplant. Survival was okay initially, and the median follow-up here is a little over 2 years. And the folks who dropped out due to progression of disease, although 3/4 of them achieved at least a VGPR. Bortezomib. Well, I am of the opinion that we owe Deb Dunsire and Dixie Esseltine a great debt because of their willingness to take bortezomib into the clinic in the first decade of the century for AL amyloid patients. Without a doubt in my mind, this is the best multi-center trial that's ever been done in relapsed AL. The advantage that the trial designers had was that at the time, no one got bortezomib up front. And the impressive use of different dose and schedule levels, demonstrating that even at lowish doses, the drug was active, was really very, very encouraging. IV bortezomib was given in this study, and we were able to push the weekly dose to 1.6 milligrams per meter squared. The incidence of neuropathy was not overwhelming. We were very impressed with the fact that there was less neuropathy than expected in this trial, and the median survival was about 5 years for this cohort of relapse patients. And this is an example of a patient. We treated her on study in whatever this was, 2003 maybe. And initial marginal response, then she got Thaldex on trial, and then she began to progress. These are her light chains. Her albumin remained really punky. Her proteinuria remained quite elevated despite having this what we would now call a VGPR. And most concerning, here we are 3 to 4 years after her therapy, her BNP started to rise. She got bortezomib on the weekly schedule. She got 1.6 milligrams per meter squared. She immediately responded and remained in a CR until August of 2017, at which time I referred her to Dr. Sanchurwala for the daratumumab trial. She's in another CR with her albumin normal and her proteinuria much less than 500 milligrams a day. Daratumumab. Okay, we have Angela to thank for this wonderful table that she just published describing the features of the trial that was done in relapse patients with daratumumab in the US, the trial that was done in France, and then a very important patient series, which Angela highlighted in her editorial from Stefan Schonlein and Uta Hegenbart in Germany. And I just want to look at this column here. This is daratumumab, the anti-CD38 monoclonal antibody approved late in 2015. This is the V is bortezomib, and the D is dexamethasone. And what we see here, what's unique about this group is that didn't matter what your plasma cell infiltrate was, you could have a heavy plasma cell burden, and it didn't matter whether or not your NT-pro was greater than 8,500. So these folks enrolled 40% stage 3B in this series, which they reported. Now, what's really, really impressive, high response rate, organ responses, and PFS of 19 months and overall survival not reached. So this sort of points out that the promiscuous availability of daratumumab to be combined with other agents is really a huge plus, and the ability to combine it with sub-Q Bortez is a real benefit for patients in the relapse setting. And then, of course, there is Andromeda. Andromeda is without a doubt the most important phase 3 trial ever conducted in newly diagnosed AL. Andromeda, for those who are unfamiliar with it, is a randomized prospective trial. Accrual has been completed, thank God, and data lock is for reporting and whatnot is days from today, maybe even a day from today. And the data will be coming out over the next year and a half. But we certainly hope that the results are as promising as they appear. The trial is the anti-CD38 monoclonal antibody, daratumumab, plus minus the standard therapy, cyclophosphamide, bortezomib, dexamethasone, versus the standard therapy. And the ramp-in required by the FDA was conducted as the initial part of the trial. All 28 patients in the safety run-in received Dara Cyborg-D. In fact, we had to admit them for that first day of therapy. And these data have just been published in Blood last month. And as you can see, 82% VGPR or better. The remainder of the patients all achieved partial responses. And this modified CR concept had to be invented because daratumumab with Cyborg-D drove down the level of the free light chains to the point where the ratio was not calculable. So from a technical point of view, the light chain level for patients, the involved light chain level, was driven down below the lower limit of the assay, and therefore the ratio was not normal. Now, the lower the light chain, the better. I think that's a message that Angela conveyed, and it's one I'll reinforce. But what this meant for these finely trained and brilliant statisticians at Janssen was that something had to give here, because this was unexplored territory. And fortunately, under the leadership of Jordan Schechter and Brendan Weiss and Jessica Tumulen, the agency has accepted the importance of this result. And therefore, what we have here is a really, really promising combination therapy for newly diagnosed AL amyloid patients. The organ response data is equally stunning, particularly in view of the fact that as you've seen, the organ response frequency correlates with the frequency of hematologic response. This is sort of what you'd expect. And the criteria for complete response do need to be updated, as Angela indicated. The modified CR does allow an involved free light chain below the upper limit. This should be lower limit of normal. And again, a marrow is not required, although I totally agree with Angela's point about additional studies. What we've done is we've looked at the stringent criteria that have been described. And we looked back at 133 patients who achieved a VGPR or better at our center. And what we noted was that those whose free light chain level was below 10 milligrams per liter as best response, the involved free light chain less than 10, they had a dramatically better long-term survival. And this is 10-year survival here. Those whose free light chain levels were 10 to 20 or greater than 20 had median survivals of between 8 and 10 years. Ixazomib, very important drug, really, really highlighted when it entered the clinical arena to treat relapsed AL amyloidosis using the criteria from the 2005 and 2012 publications. However, as we learned in the middle of last year, one of the primary endpoints for interval evaluation was not met. The hematologic responses were no different between those who got an Dex and those who got dealer's choice, physician's choice. However, the second analysis finally revealed big differences between patients who got Ixazomib Dex and those who got dealer's choice. One of the big differences was the median duration of response. Interesting. Another big difference was the improvement in time to organ deterioration or death in those who got Ixazomib Dex. Unfortunately, despite pleas from Takeda to the FDA would not allow the drug to be approved for AL. It remains a real challenge to get the drug up. I do believe it's a very, very useful drug, especially in the relapse setting. And one of the most unfortunate things is that a clinical trial of maintenance, 2 years Ixazomib maintenance, opened. Heather Landau accrued about a dozen patients. We had 3 patients on the study at Tufts. And Takeda closed the trial, pulled the financing, and I think they're allowing drug supply to continue for those who enrolled, but they've really sort of turned the other way when it comes to AL right now, unfortunately. We must do better. The Tourmaline trial, which is the one I just described, is one of 2 trials that were stopped for futility. The other was the NEOD-001 trial. And we have to do better as we go forward for this population of AL patients who have relapsed disease. Unfortunately, I don't think we're going to be able to get venetoclax approved for AL in the near-term future. We've been struggling with this issue. I'm grateful that other BCL2 inhibitors are entering the clinical arena because we'll have a shot there. But, you know, we knew early on that CCND1 overexpression due to the 1114 was probably not a good thing. We knew this years ago. And when we began to get venetoclax for patients, particularly those with the 1114, we saw a hint of activity. The responses were really remarkable, just as the responses in vitro had been for myeloma cell lines expressing the 1114. And thanks to Vic Premkumar and Suzanne Lench, numbers were pulled from investigators around the world. And what we have here is one of the figures from a paper that's in submission. I'm using this with their permission, showing that the 1114 cases of AL had a median survival, this is actually PFS, that was not reached, whereas those with a relapsed AL given venetoclax had a median PFS that was a lot shorter. So the hazard ratio is clearly quite high, but the bias is there for the 1114. And this represents outcomes in 30 patients. And these are their responses. Responses parallel daratumumab in terms of the comparison. And it's very, very interesting to see how quickly patients respond. What we do is we start at 200. We don't ramp in. It's not CLL. They don't have a high tumor burden. They don't have bulky disease. 200, and then in 2 weeks we go up to 400. I've not had to go beyond that, but there are others who've had to go to 600 milligrams of venetoclax. It's extraordinarily well tolerated. You just have to watch the platelet count. I have not added other things to it as a rule, but there are clearly advantages perhaps to adding Ixazomib or Velcade or Dex perhaps. And then anti-BCMA, again, a novel therapy in the wings. We have studied BCMA and AL, and what I can tell you is that the soluble form is present in the plasma of patients with AL, and it does appear to be reduced in those who have a hematologic response. The ratio of soluble BCMA to lambda light chains is really linear. The correlation is linear. So the soluble BCMA is a pretty good measure of burden of disease. And it also correlates with plasma cell infiltration. Well, these data were just published by Dr. Gadara earlier this year. When you use the gamma secretase inhibitor that prevents the shedding, what you see in patient cells in vitro is an increase in membranous BCMA. And what you see in the culture is a marked decrease in soluble BCMA as the membranous BCMA increases. Now, you know, we've got a smorgasbord of BCMA-related therapies. The only two I think are worth looking at for AL perhaps are the antibody drug conjugate and the BiTEs. Now, we are hopeful under the leadership of investigators from UT Southwestern and from Mayo Clinic that belantamab mafodotin will be in an early phase trial, phase 1 component and the larger phase 2 component. We're very hopeful that it will be for relapsed AL. There are multiple other BCMA CD3 bispecific antibodies. That's what this symbol represents. I've spoken with folks at Janssen, spoken with Amgen. 2 weeks ago, I spoke with folks at Regeneron who are otherwise occupied now, obviously. And interest is there. And eventually they will come around once they have sorted out the features of the early phase studies. Well, they'll come around to AL. There are other targets and other types of bispecific antibodies under development. The bugaboo here remains cytokine release syndrome. And as more is learned about that, about how to manage it, about dosing and the time frame of its occurrence, we may see some availability of these agents for AL. So where are we? We're where the angel of history is. Walter Benjamin, 80 years ago, described this, I think it's a woodcut by Paul Klee. This is how one pictures the angel of history. His face is turned toward the past, where we perceive a chain of events. He sees one single catastrophe which keeps piling wreckage upon wreckage and hurls it in front of his feet. The angel would like to stay, awaken the dead, and make whole what has been smashed. But a storm is blowing from paradise. It has got caught in his wings with such violence that the angel can no longer close them. The storm irresistibly propels him into the future to which his back is turned, while the pile of debris before him grows skyward. This storm is what we call progress, and it's a true hope that progress continues to occur for this disease. In conclusion, for patients, there are many options. Relapse after a durable remission. Very often you can go back to what they were treated with initially if it's been a couple of years after initial therapy and the relapse is manageable. Ixazomib Dex, I think, is an option if you can get it. Clearly, daratumumab Velcade Dex or daratumumab Ixazomib Dex is an option, and venetoclax is an option if you can get it for the 1114s. You have to go through an appeal process often, although some insurers will agree to provide it. primary refractory disease, these are the options. Clinical trials remain extremely important for all stages of disease. I do believe we have to optimize hematologic response, get the IFLC as low as possible. If it is less than 10, I'm not sure MRD is needed, but you could argue that, you know, that needs to be evaluated further. And I take issue partially with the notion of organ response, because I think what the agencies really want to see is impairment of progression to organ damage. So while I respect organ response criteria and their development, I do think we have to pay a little more attention to the features of organ progression. And as the relapsed trials are designed, I would emphasize perhaps on a phase 3 level, if we ever get there, that the difference between the arms in terms of progression of organ damage is important. And obviously quality of life is very important. And I just want to highlight once again the EGFR slope in that case I presented. And I do want to thank you for your attention. Thank you.
Thank you so much, Dr. Comenzo. That was a very, very fascinating talk. A lot of good questions are coming out of that. So I just, I will have to save them for the end because we need to move on to our next talk. So just hold everyone your questions for the end, and we'll get to them later. But our third and final speaker is Dr. Ron Witteles. Dr. Witteles is a professor of cardiovascular medicine at Stanford, and he is the co-director of the Stanford Amyloid Center. He did his internal medicine and cardiovascular training there at Stanford and has vast clinical and research expertise in cardiac manifestations of both AL amyloid and ATTR amyloidosis. His research focuses on novel therapies for all types of amyloid, defining the role of organ transplant and pacemakers or defibrillators, particularly in cardiac amyloid. And then he also partners with basic science labs to explore basic principles of pathogenesis in this disease. Dr. Witteles will be speaking to us about the role of medications, rhythm management, and heart transplant in amyloidosis. So go ahead, Dr. Witteles.
Thanks so much. I want to thank Drs. Cossor, Sperry, the whole team for putting this conference together. It's really great to see, and it's a nice opportunity to make a little bit of lemonade out of the definite lemons of the whole COVID pandemic, to be able to bring people together virtually to discuss these topics. So thanks for the invitation. Go ahead and jump right in. So first off, I want to talk about what I will group under heart failure medications. And I will emphasize that unlike what I'll be speaking about later in the talk, this is really a largely evidence-free zone. So a lot of this is going to be opinion-based, though I think for the most part are going to be opinions that most everybody who manages patients with this disease would share. So we're going to talk about diuretics, these so-called goal-directed medical therapy agents in heart failure, a little bit about midodrine, and then a few words on digoxin. So in terms of diuretics, I would say that probably the biggest thing that we can do as cardiologists is to adequately diurese patients. Now, that is probably true largely for heart failure patients in general, but it is doubly true for patients with amyloidosis. Probably of every 10 new patients I see referred for amyloidosis, I'm probably increasing diuretics in about 8 of them. So why are patients underdiuresed? Well, a combination of several things. Low blood pressure, which is of course a combination of their poor cardiac output and then often autonomic dysfunction and proteinuria. Kidney dysfunction, so particularly if there is direct renal infiltration in patients with AL amyloid, there's a hesitancy to push ahead and diurese them because you're trying to keep the creatinine down mistakenly. And third is a mistaken attempt to try to get traditional goal-directed medical therapy on board for heart failure, which we'll get into a second. Edema, ascites, effusions are often present from, again, that combination of heart failure and then proteinuria in particular in AL patients. So when it comes to the management principles, I'd say the following. First off, you just have to bite the bullet and adequately diurese the patients. What happens a lot of time is that patients are, renal function is tried to be protected, and they are left drowning in fluid to try to have the creatinine number be better. And I promise you, there is no patient who would rather be drowning in fluid and have a lower creatinine level than vice versa. Number two is not to be put off by hypotension. Again, you have to push ahead and get them adequately volume managed. And in some patients, again, particularly AL patients with autonomic dysfunction, midodrine can be a helpful adjunct. Three is that often it's going to require a dual or even triple ion channel blockade, meaning a combination of loop diuretics, spironolactone, and a thiazide. I usually would go to hydrochlorothiazide in such cases, as these patients are typically very salt avid because of both their kidney dysfunction with proteinuria and heart failure. With this, of course, they need very frequent lab checks, particularly with any diuretic changes. Salt restriction because of the kidney salt avidity in these cases will be critical. Compression stockings can be particularly helpful in patients with nephrotic syndrome. And in patients with nephrotic syndrome, I'll say that while I wouldn't do this just routinely in the case of proteinuria, there are certainly cases of severe nephrotic syndrome where you have patients who have serum albumin levels that in the low ones or even less than one, that the only way to get them through is to have regular scheduled albumin infusions twice or even thrice weekly that will allow you to keep the blood pressure up, get the volume off, and prevent them from going into frank renal failure. We've definitely saved a handful of patients this way. Now, in terms of success, traditional goal-directed medical therapy, the main thing you want to do is just say no. For a couple of reasons. One, the mechanism of the injury and the disease progression is very different from somebody with an ischemic cardiomyopathy or dilated cardiomyopathy, where it's largely from neurohormonal upregulation and the chronic damage from that. Obviously, in this disease we're talking about, the vast majority of the damage is coming from new amyloid deposition. But most importantly, it's just very poorly tolerated because of a couple of reasons. So one, the hypotension that I was referring to before. Again, this is particularly so in patients with AL amyloidosis because of the frequent concomitants, proteinuria and autonomic dysfunction. And then for beta blockers in particular, patients with cardiac amyloidosis, of course, tend to have small stroke volumes because of the small cavity size, and therefore often will need a faster heart rate. And particularly with transthyretin amyloidosis, heart block is common, and obviously beta blockers can cause problems there. So can they ever be used? The answer there is yes. So beta blockers, I'm going to speak more to in a moment about atrial fibrillation, sometimes are needed for adequate rate control. You would think that patients with a lot of amyloid infiltration would have enough AV nodal disease that this would never be needed, but sometimes you are surprised how fast patients can conduct. And then I would say, in terms of all goal-directed medical therapy, never say never. And in particular, patients with longstanding hypertension and often older patients with wild-type transthyretin amyloidosis, and they may come to you on a beta blocker and an ARB, for example, and their blood pressure is 140. I would definitely not advocate taking those medications off in such a case. So in somebody with frank hypertension, particularly if there's some concomitant systolic dysfunction, it can still be reasonable. Midodrine, I referenced earlier, can be particularly useful for patients with autonomic dysfunction. Remember the side effects. Most people will get some dry mouth, but what you really want to be careful about is the urinary retention, particularly in older men. So how about digoxin? So this has traditionally been considered contraindicated in cardiac amyloidosis, with the concern being that digoxin will bind to amyloid fibrils and cause toxicity, maybe even with normal serum levels because it's binding to the amyloid fibrils. But when you actually drill down, the articles that are typically cited are from 1961 and 1981. So we're about to hit the 50th anniversary, so it's probably time for a fresher look. A couple studies I want to point to, one that came out of Mayo Clinic in 2018. They had 107 patients, all with AL amyloidosis, who received digoxin over a 15-year period with pretty standard dosing and a median duration of 5 months. Now, 11 of the patients did have arrhythmias on digoxin. 5 patients had terminal arrhythmias, 4 that started as bradycardia and then went to VT or VF. and one that just went straight to VT as a terminal arrhythmia. They did note that all 5 had acute renal failure and severe decompensated heart failure, so likely did not have a long life expectancy with or without the digoxin. The conclusion was that digoxin may be cautiously used in AL amyloidosis patients. I suppose that depends if you're a glass half full or glass half empty sort of person. It does give me some pause, I must admit, to have 4 patients who had arrhythmic deaths that started off as bradycardia. And so I think highlights that certainly if you're going to use it, particularly bradycardic rhythms should be a real concern. Another study that's so far been reported in abstract form only from Cleveland Clinic, 2019, looked over a little bit longer time period. Ultimately, 71 patients treated for at least a week with digoxin, a mix of transthyretin and AL patients. Notably, the indication, only 2/3 of the patients had it indicated for rate control. Another third was for decompensated heart failure, which I would not generally recommend using it for that purpose in this population. They had 10% of patients with suspected digoxin-related arrhythmias. 21% died while on treatment. That doesn't mean it was from the dig, of course. 10% had the suspected dig-related toxicity, and they felt that 1 death was potentially attributed to digoxin. And once again, glass half full, glass half empty, they said digoxin may be used cautiously in selected patients without good rate control or heart failure options. I think I agree with the former, not so much with the latter. So my take, and that is me, my digoxin purpurea purple shirt on next to a digoxin plant. You can find, or a digitalis plant, I should say, you can find them growing all over. They're very pretty purple flower, although the actual plant that is used to create digoxin is digitalis lanata, which is a less pretty white flower. But anyway, if you keep your eye out for it, you'll find it. I would say it's not 100% contraindicated in amyloidosis patients. I would not use it for heart failure, but I would and do use it for challenging rate control patients. But I definitely feel better about using it for patients who have pacemakers in place, because I think the main concern is really about bradyarrhythmias with it. Well, let's talk about atrial fibrillation. It's common, probably particularly common in transthyretin amyloidosis. Rate control agents, as we just talked about, are often poorly tolerated. Sometimes they aren't needed, but sometimes they are. Rhythm control is frequently attempted in amyloidosis patients with atrial fibrillation, as it's often poorly tolerated. Patients with cardiac amyloidosis are often living on the cusp of relative low cardiac output, and just that loss of the atrial kick, and sometimes the rates being off one way or the other, can be enough to really push them into decompensated heart failure. If you're going to use antiarrhythmics, there's really not good evidence to drive this. I'd say amiodarone is the most frequently used. In terms of cardioversion, the data would suggest that the early success rates are similar to patients without amyloidosis, but recurrence rates are higher. And in terms of atrial fibrillation ablation, there's again very little data, small studies, but generally do support decreased recurrence rates. And I would say, while it's clearly not as good as for other causes of atrial fibrillation, in the right patient, it can still make sense. This was a table from a very nice recent review in JACC-EP that was looking at arrhythmias and amyloidosis. And they looked at studies, and I've circled the pooled prevalence of atrial fibrillation. And you can see, particularly in the more recent studies, you see averages probably about 25, 30%, which I would say rings true with personal experience. Now, very importantly, as data has come out, particularly in recent years, is of the high rate of left atrial appendage thrombus in patients with amyloidosis. And this is probably because the atria are so diseased and because the cardiac outputs tend to be so impaired in these patients. So this was a nice study comparing the rates of atrial thrombus before a planned cardioversion in 58 patients with cardiac amyloidosis and about twice as many matched controls. Now, not everybody got a TEE, but it was based on the guidelines and the provider's clinical judgment. And then they looked at the thrombus rates. And if you look at where I circled below, 2.5% of the control group had thrombus seen on TEE. 28% of those with cardiac amyloidosis had it. And it was pretty similar, actually, between AL and transthyretin. This is a table from that JACC-EP manuscript I was just mentioning, showing a few recent studies that have looked at this. And again, you see it's in that sort of 25, 30% range or so. And two of the studies noted that in one of them 46%, and in the other 88% of patients who had been therapeutically anticoagulated for at least 3 weeks, or in one of the studies had AFib less than 48 hours. These are patients we would not normally think would need TEEs. 46% and 88% in the other of the patients who had thrombus fell into those categories. So the big picture takeaway from this is that probably every patient getting a cardioversion with cardiac amyloidosis should undergo a TEE beforehand, regardless of anticoagulation status. Let's talk about devices. So pacemakers are fairly straightforward. Bradyarrhythmias are common, particularly heart block related to transthyretin amyloid infiltration. My suspicion is that we see it more in TTR than AL, just because the overall burden of amyloid deposition tends to be higher in transthyretin. And the criteria for placement of a pacemaker here is pretty straightforward. It's like anything else, symptomatic bradycardia. How about cardiac resynchronization? I'll get to in a moment. But let's look at defibrillators for a moment. Do they work? When should they be considered? And sort of an old paradigm that you'll hear, and put some quotes that I've heard over the years many times about reasons not to put defibrillators in patients with amyloidosis. I'll just read the one on the bottom, which is probably the most common statement, which is, look, the prognosis is terrible in amyloidosis. Why would you want to convert a peaceful sudden death to a miserable heart failure with gruesome shocks death? And that probably made sense 20 years ago when the prognosis was so much worse. And when patients who were diagnosed with cardiac amyloidosis tended to really have severe overt disease and very poor life expectancies from it. But how about in more recent years as therapies and diagnostic abilities have improved? So this was data out of Germany, 19 patients with AL amyloidosis. They were all getting stem cell transplants and felt to be at high risk for sudden death based on their cardiac involvement. You see that this is an overall sick population. There was multi-organ involvement in most patients. And during a mean follow-up of a little more than 2 years, there were 7 deaths, 6 from what they described as electromechanical dissociation. I suspect this was largely just patients who were found dead or had sudden death. 2 went on to get heart transplants. 9 didn't have any therapy or transplant and were alive. And the one I want to point out, who had multiple shocks for VTVF, survived, ended up on amiodarone, and was alive 30 months into the study, was still alive at the report. So how do you interpret this? The manuscript is sort of putting it forth as it's not a great option. But I would argue there was one of these 19 patients who was pretty clearly saved for a minimum of 2.5 years, and who knows, maybe much more, from placement of the ICD. That's actually really not bad. Here was data out of Mayo Clinic from the 2000s, where they looked at 53 patients who had undergone ICD placement, mainly for primary prevention. So keep in mind, that means that their EFs were under 35%. So these were of particularly ill patients. About a third of them had appropriate shocks in the first year, which is a lot compared to most patients who are getting primary prevention ICDs. So it shows, again, there's a sick population. The AL patients, maybe not surprisingly, were more likely to need shocks. And though there was no clear survival advantage, it certainly wasn't a study powered to find that. And again, you're talking about a particularly sick patient population who, by definition, those 41 had EFs under 35%. We looked at our data at Stanford from 2008 to 2012, where we had 31 consecutive patients who had cardiac involvement, but without advanced heart failure. We offered them ambulatory telemetry monitoring with Zio patches for 2 weeks. And 3/4 of them had significant burden of non-sustained VT, 19 of whom went on to get defibrillators based on this. In a pretty short follow-up time, 6 of those 19, so again, about a third, had appropriate therapy for sustained VT, and the rhythm was successfully broken in 5 to 6 of those patients, meaning that one of those patients had died from EMD. I can say since that time, we've had many, many patients who've gone on and gotten devices. We've not yet had one other patient where the device was unsuccessful in resuscitating from an arrhythmia. So our practice is to consider ICD if their life expectancy is reasonable. We say greater than a year, but usually it's quite a bit beyond that. And either they have a suspicious history of non-postural related syncope or VT seen on telemetry. And this was the algorithm that we proposed, which is essentially along those lines. And then finally, there's some data from France from 2008 to 2014, which were 45 patients, kind of a similar patient population, again, mix of AL and TTR. If you look at it, 12 patients, or about a quarter, had appropriate ICD therapies in that short follow-up time of only 17 months. And look how many therapies we're talking about. 52% of patients had, actually not 52%, 52 therapies were given for VT, and 5 were given for VF, which is an incredibly large number in only 45 patients. And what's more, the therapies tended to occur early. The average time was 5 months, and 11 out of the 12 who had therapy had it in the first year. And every single time the device was successful in terminating the rhythm, although one patient died of PEA arrest despite getting successfully cardioverted from the device. But in the other 11, they all lived. Now, does that mean all of those 11 would have died without shocks? Of course not. But undoubtedly, several of them would have. So again, I would look at this as a success. Here's a table from that recent JACC-EP article. And again, you see from a number of different manuscripts, including the ones I just showed here, you're talking on average about a quarter or so of patients will have appropriate ICD therapy, all with pretty short follow-up. So these are sick patients where it really seems like it can make a difference. And then for cardiac resynchronization therapy, or BiV pacemakers, so it seems like a good idea for those with left bundle branch block or those needing chronic ventricular pacing. Anecdotally, I would say it works in that population, although there's not a lot of good published evidence. There is this recent study that was published out of Cleveland Clinic where they looked at patients. About a third of the patients were getting RV paced, but rarely. About a third of them were getting RV paced a lot, and about a third of them had been given BiV pacers. And if you look down at the table below, what I've circled is the NT-proBNPs at baseline and follow-up, and you can see that the NT-proBNPs about doubled in those with occasional RV pacing. It really increased by about 7-fold in patients who had frequent RV pacing, and it stayed about the same, maybe went down a tiny bit in those getting CRT. Not high quality evidence, but I would say goes along with anecdotal experience. Interestingly as well, 38 of those patients had defibrillators as part of their BiV pacemakers, and 8 of those 38 received appropriate ICD shocks. Again, that sort of 20 to 30% range. The mean time from the first shock to death or the last follow-up was 2.5 years. So once again, undoubtedly, they did extend life, and not just by a week or two, but on average 2.5 years at least, because some of them were still alive from having the defibrillator. So the take-home points I would say on devices is that pacemakers are commonly needed in amyloidosis patients, particularly transthyretin. There's probably a role for CRT in those cases I mentioned. Defibrillators, well, they don't have a lot of trial evidence, but I would say the preponderance of the evidence says it probably does make sense in the era of better amyloid therapy for patients who are higher risk, particularly AL patients. And again, I would say my anecdotal evidence from the last few years has definitely been positive. How about LVADs? LVADs are generally not a great option for patients with cardiac amyloidosis, and that's for a few reasons. The biggest is that the ventricular cavities, of course, tend to be small, and as we'll see the data, that really does not work well with LVADs. Secondly, the RV is every bit as much involved with cardiac amyloid as the LV. In fact, right heart failure tends to be the predominant symptoms that people have, and LVAD obviously won't help with that. And third is that for AL patients, they're getting chemo or immunotherapy, which is going to raise your risk of device or driveline infection. But does it ever make sense? Yes, just very limited cases. Probably if you're picking people who happen to have larger cavities and where the clinical RV failure isn't as bad. There's one study worth looking for out of Mayo Clinic from 2015, which was looking at 28 consecutive patients who had end-stage restrictive cardiomyopathies, 10 of whom had amyloidosis, 18 of whom had other restrictive cardiomyopathies, who had gone on and received LVADs. And if you look at the survival amyloid in black and the black line and the non-amyloid in the dotted line, and you can see it's about the same between amyloid and the other restrictive cardiomyopathies, although the overall survival here is really quite poor compared to most patients who get LVADs. And I think this was the most telling thing, which was that rather than breaking it down by amyloid or not amyloid, they broke it down among this restrictive cardiomyopathy cohort, among those who had small ventricles, which they defined as less than or equal to 4.6 centimeter end diastolic dimension, or greater than 4.6. And you can see really a dramatic difference. So don't put it in the people with small ventricles. It will not work. But occasionally for end-stage heart failure patients who have larger sized cavities, it can make sense. And then I want to focus the rest of our time on heart transplant, as this is, I would say, becoming increasingly common for patients, not still, most patients with amyloidosis have it, but for the right patient, it can be a very good option, as we'll see. So originally, it was really thought to be crazy, that the outcomes in the 80s and 90s were terrible. These were mainly patients with AL amyloidosis, mainly very late presentations, poor chemo options, and patients died from multi-organ dysfunction from amyloid infiltration because they often had AL amyloid everywhere, and even if you replaced the heart, they were left with renal failure or GI involvement, et cetera, or because they had amyloid depositing in the new heart. And again, these are mainly AL patients and without very good chemo options. But what if you selected patients who had little to no significant extracardiac involvement, and for the AL patients, you gave them effective therapy? Well, in the early 2000s, the results were still discouraging. A report out of the UK had a median survival of 29 months, which is really terrible. The one-year survival of 59%, again, for AL patients, again, really unacceptably low. In 2005, there was a report through UNOS, which is the the network for organ transplantation in the US over 15 years. And you see the survival is better, but still not great and still statistically worse than the non-amyloid transplant survival. Keep in mind that the average survival after heart transplant for all comers in this country these days is about 11 years. Men seem to do a little better than women, probably because UNOS doesn't break down between transthyretin and AL, and that probably means that more men had a transthyretin, which we know to be the case. Mayo Clinic published their experience in 2008. These were all AL patients. Now, note, this wasn't a lot of patients. This is 11 years, 11 patients, so averaging one patient per year. And the key was that everybody was screened extensively for extracardiac involvement, and then they all underwent stem cell transplant afterwards. And you can see that the survival, while worse than the average heart transplant in all comers, maybe was getting more acceptable, about close to 6.5 years. So getting closer to reasonable. Here was data out of Colombia. They looked at 25 patients who had been referred for transplant evaluation over 7 years. They ended up transplanting about half of them, mainly AL patients. They used extended donor criteria, so taking some hearts that they might not have used for other patients. And they did stem cell transplant 6 months after. If you look in the upper right, you can see that the group who got transplanted is in the upper curve and does, reasonably well. Now, keep in mind, look at the x-axis. You're talking about follow-up days. So, it still looks like maybe it's a little bit worse than the overall population, but not terrible. Those who didn't get transplanted, though, you can see quickly died, and that's a theme we'll come back to. And then our experience out of Stanford. So we published this in 2015, and we literally just last week had our updated data published in JACC Heart Failure, published online before print last week, but you can access it now. And so we looked at 31 transplants that we did, all 31 over that 13-year time period, a mix of AL and transthyretin. For candidacy, it was all the usual standards for heart transplant. And then for AL, we did extensive screening for significant organ dysfunction, and everybody underwent EGD and colo with random biopsies. That it wouldn't be that they would be automatically excluded if we found any amyloid, but we would take that along in the context of any symptoms or malnutrition, whatnot, in terms of deciding on their candidacy. For transthyretin for the wild type patients, it was really no different than for any other patient being evaluated for heart transplant. And for the variant or hereditary forms, it was based on mutation and symptoms. In terms of light chain suppressive therapy, and this was not true for some of the other studies I mentioned, we tried to begin it pre-transplant, and we generally wanted to see that the light chains had really gotten under control before we proceeded to heart transplant. It wasn't an absolute, but we were really reluctant to if we didn't see this. And we would then begin it again as early post-transplant as possible. And for stem cell transplant, we really started moving away from this a few years ago, and now only started using it as needed if we couldn't achieve adequate free light chain control, given the improvements in the chemo and immunotherapy options, as you heard about from our last two speakers. And in fact, over the period we studied after 2013, none of our patients who had heart transplants received a stem cell transplant. If you looked at the patient characteristics, I'm just highlighting a couple things. You can see that, so 5 out of our 13 AL patients ended up getting stem cell transplant, mainly the early ones. And if you look at days to transplantation, they were pretty short. So 42 overall and 23 for our AL patients. That's from the time of listing to getting transplanted. And that has to do with prioritizing them and being fortunate to be in a part of the country where we tend to have a shorter wait list than many other spots. If we look at extracardiac organ involvement, it's the usual stuff, lots of carpal tunnel in patients with transthyretin, for example. If you look at GI involvement in the AL patients, 40, 50% of them had mucosal amyloid deposits. But again, just having that alone wasn't the reason why we excluded. It was really a combination of the pathology and the symptoms. If we look at adverse events, you'll note down at the bottom there that only 1 out of the 31 patients has had any evidence of amyloid in the new heart. And that was 1 AL patient who had some challenges early on with light chain control and had only very mild deposition and has not had any clinical heart failure or any other clinical problems related to that. And if we look at the number of patients who have died, you can see that we have only had 4 total deaths and only 1 of our AL patients who's died. And I'm happy to say that none of the deaths had anything to do with their amyloidosis or amyloidosis treatments. There were 2 infectious deaths in the transthyretin patients, and then 2 patients who died of malignancies that were unrelated to hematologic malignancies. If we look at our free light chain control, we're looking at the percent reduction in the difference in free light chains on the y-axis. And you can see that generally it's been quite successful, both for patients who have got stem cell transplant in green and those who didn't in blue. Again, these days we can generally control light chains quite well for most patients. And if we look at survival, this is the Stanford data looking at our amyloidosis patients in blue and our all others in orange. And as you can see, it compares quite favorably. And clearly from this data, we're happy with the outcomes and don't feel like we're quote unquote wasting organs for patients who are going to have poor survival. They've actually done quite well. And then this is a really important figure. This was a data out of MGH that looked at what happened to patients who were listed for transplant who didn't get transplanted. And you see for all other diagnoses, they could actually live for quite a while. Whereas for patients with AL amyloidosis, if they were on the list and they didn't get transplanted, they died very, very quickly. And it just gets at how high risk a population this is. We looked at the national data as well with heart transplants, and we looked again at that UNOS registry, which is all transplants in the United States. And we predefined 2 different eras, era 1 and era 2, with 2008 as a cutoff date, because that's when the newer therapies, the IMiDs, the proteasome inhibitors, really started coming on the scene for AL amyloidosis. What did we find? Well, 1, the transplants for amyloidosis have become considerably more common, so they quadrupled as a percentage of overall transplants between those 2 eras. If we look at survival, you can see the amyloid patients in blue and then all others in red. And so era 1, they clearly did much worse. Era 2, it wasn't quite statistically significant, but still a suggestion that they do somewhat worse. But if we compare more apples to apples, which is amyloid patients to other patients transplanted for restrictive cardiomyopathies, while they did do worse in era 1, by era 2, you see that the curves are really largely overlapping. So the remaining questions in heart transplantation for AL amyloidosis, what is the role of stem cell transplants? Again, we do not tend to do it routinely now. Other centers do. I would say there's still no clear data-driven answer on this yet. When should light chain therapy be begun? How important is it to see the light chain response before doing the heart transplant? When should you initiate it afterwards? And what's the right balance of anti-rejection meds versus the chemoimmunotherapy? These, I would say, again, they're just awaiting more data. For transthyretin patients, there's an interesting phenomenon that we and others have certainly observed, which is that when you take the heart out, this sink for the transthyretin amyloid deposits, you'll frequently start seeing a lot more transthyretin deposits outside of the heart, even in some of the wild type patients. And then who should get stabilizers or silencers post-transplant? There's no data, although I think most of us think probably most or all of these patients should. So in summary, for heart failure medications, please generally avoid the quote-unquote goal-directed medical therapy. You can very cautiously use digoxin, but I'd recommend only using it for rate control of AFib. Definitely use, and probably more aggressively, use diuretics. And then for the right patient, midodrine or even albumin infusions. For rhythm management, for atrial fibrillation, it's common. Remember to anticoagulate and to really always rule out thrombus with the TEE prior to cardioversion. For VTVF, I think ICDs do have a role in select patients, particularly in the AL population. And we don't have good data on cardiac resynchronization therapy, but in patients with left bundles or who are going to necessitate RV pacing, I think it makes sense. LVADs have a very limited role, but have you can consider it if there's a larger cavity and they have end-stage heart failure. And transplant, again, has a growing role overall. It's more straightforward for transthyretin, but more complicated for AL, but it can still be done and should, of course, be done in specialized centers. I just want to highlight, I'm fortunately one of the associate editors for JACC Cardio Oncology, which we've really tried to set up as a home for amyloidosis research, both for AL and transthyretin and, well, any other amyloidosis. So please consider submitting to us if you are submitting something. And I just want to acknowledge the tremendous team we have at Stanford. I think as everybody who's involved in caring for these patients knows that to care for amyloidosis patients, you really need a large multidisciplinary team to collaborate. And we certainly have one that I'm very lucky to get to work with at Stanford. And I will stop there. Thank you.
Thank you, Dr. Witteles. That was a fantastic talk. We actually had a few very good questions. In fact, I think this question would be a good one for Dr. Comenzo, Dr. Dispenzieri, or you, Dr. Witteles. So someone in the audience had asked, you know, we're seeing more solid organ transplants happening in patients with AL amyloidosis, be it renal or cardiac. And, you know, IMiDs are generally not recommended up front, but for relapse disease later, what is the safety of using IMiDs in that context? Anybody can pipe up?
Well, you know, I think Angela probably has a fairly good handle on this, but in my limited experience, I would not use immunomodulatory drugs post a solid organ transplant. I would be very reluctant to use them because of the possible impact they might have on risk of rejection.
Yeah, I would agree. I think, you know, there are so many options. And again, in general, we're not recommending maintenance therapy in a lot of these patients. And so, you know, a lot of people who end up with organ transplant, it's in the context of, you know, their disease was very advanced at diagnosis and, you know, there just couldn't be enough repair. There are patients who, you know, don't have their disease under control, but those are the patients that you're less apt to actually give an organ, given how, you know, what a precious resource that is. So, it doesn't come up as often as one, you know, might think.
Yeah, and I can refer you to a paper that one of Furha's colleagues from fellowship, Shakur Salugan, published in Clinical Lymphoma, Myeloma, Leukemia, a series of patients post solid organ transplant who received daratumumab. And it included one of our patients, a long-term survivor who got a heart transplant 16 years into the disease and had relapsed amyloid. We started him on Dara, Velcade, Dex. This would be now about 2.5 years ago. He did fine and went into a remission, continued on monthly Dara, and then developed nocardiobacteremia, which required extended treatment. The transplant ID team and the cardiologist at Tufts did a great job with him. He's fine. But what Shakur was able to do was compile, I think, a series of about 8 cases, which are now published, showing that you can use daratumumab post-solid organ transplant despite the increased risk of infection. You probably do have to prophylax aggressively when you're using it.
That's not approved.
Yeah, and I'll say from our experience as well, yeah, we tend to avoid the IMiDs for the same reasons. We've definitely used Dara on a number of patients, and it's also definitely allowed a couple of patients to get transplants who otherwise just weren't having a good enough hematologic response pre.
So that actually brings up a second question that we had thought of, and this is for probably Dr. Dispenzieri and Dr. Comenzo. You know, these agents, daratumumab and ixazomib and all of these drugs have been tested, and we want to use them in the relapse setting, but what is your experience in getting them approved and getting the drug into the patient?
Can you stop the recording for a second?
So I'll tell you what we do. I'm going to be forthright here. So when patients are diagnosed in our conference with the pathologist, we highlight those areas of the biopsy, which are always there, that have 10% or greater infiltration with plasma cells. And we encourage them to reference those areas of the biopsy and say areas are consistent with myeloma. Therefore, from the start, we have a ticket that can enable us to argue for drugs, because we code the patients as having myeloma based on that analysis. The other thing with venetoclax is that you need 2 denials from an insurer and then can go to Genentech, and Genentech's been fairly good in terms of providing it for the 1114s. But again, the diagnosis of myeloma is very important to have. So that's what we're doing, but we realize that, you know, it's sort of, how shall we put it, shaving the penny or something like that, but it's necessary for these patients.
Yeah, we don't have as much control over our pathologists per se to highlight those things, but in our, in our own notes, we kind of, sort of say, well, it's there's myeloma with end organ damage, and, a little hand waving.
Certainly. The insurers just need to know what they need to know.
Yeah.
All right, so Dr. Witteles, we actually had a couple questions for you. Actually, Brett, do you want to pose that first question that had come in?
Sure. I guess while we're on the topic of transplantation, I think Dr. Witteles highlighted something that is a question out there. Do these patients really need therapy first, anti-plasma cell therapy first, before undergoing something like heart transplant? So maybe I'll just give a second to Dr. Dispenzieri and Comenzo to comment on that as well.
Yeah, I would say, well, first of all, yes, because the reality is they're not going to get a heart instantly anyway. And so, back in the day when we only had alkylators, there was a lot of hesitation about treating because you're afraid that they'd have like pancytopenia, for weeks. And, you're not going to give a heart to somebody who has like no platelets or something like that. But now, with the number of treatments that we have, that we've gone over, that Ray mentioned, that Vishali mentioned yesterday, I think, we have so many drugs that you can give patients therapy while they're waiting. And so that tends to be our policy.
Completely agree.
Fantastic. And so another similar vein question for Dr. Witteles, and I don't know if Dr. Hanna is still on, maybe he can chime in as well. You talked about your patients in your series that you just published with ATTR not having any recurrence as far as amyloidosis in the heart. And so just talk through that a little bit more as far as what your plan is there. Do you do PYPs at a certain interval? Do you check screening heart biopsies at a certain interval? And then do you think about putting these patients on stabilizers after heart transplant, or just expect that their heart transplant or their amyloidosis is going to, be a problem much after transplant?
Sure. So as I think most everybody who's watching the symposium knows, transthyretin amyloidosis and AL amyloidosis tends to progress at very different rates, at least untreated. So for a transthyretin amyloid in general, even without treatment, it's unlikely that they're going to develop significant deposition in the heart in the realistic lifespan that they're going to have post-transplant. We, again, at our institution, haven't seen any. And we are an institution, for better or for worse, that in general post-transplant does do routine biopsies. So we will, and in any amyloid patient, we obviously specifically look for recurrence in those biopsies. So we should see it. I would say PYP scans, the thing about PYP scans is by the time you see enough uptake to make the diagnosis, there's a lot of amyloid there. So it's probably not sensitive enough to pick it up. In terms of should you use silencers or stabilizers, up until now, it's been a moot point because they weren't available. I would say that I actually these days would generally recommend at least using the one stabilizer that's approved for cardiac amyloid. Obviously, it's sort of weird to be using it for cardiac amyloid after you've taken out their heart, but it's actually less for the reason of the deposition in the heart and more what I was briefly referencing of this pretty clear phenomenon that after you take out the heart, we know that sort of amyloid deposits beget more amyloid deposits. It's sort of like a seeding, and that you start getting more deposits elsewhere. And so you'll have patients with wild type TTR amyloid who develop symptomatic GI TTR amyloidosis, for example, which normally somebody with wild type would never get, or V122I, where again, it's unusual to have much GI involvement and then they develop it. So I would actually tend to use it, albeit this is off-label, but I would tend to use it if at all possible now in patients more to prevent extra cardiac deposition. I see somebody says, how do you get approval? Well, they have a diagnosis of cardiac amyloidosis, don't they?
That's again just massaging the data a little bit.
I mean, I'm just saying they do have a diagnosis of cardiac amyloidosis.
Definitely.
Actually, I have one question that Dr. Raza and I were inquiring minds want to know, Dr. Dispenzieri. So, we see a lot of patients in the outpatient clinic with light chain or suspected light chain MGUS. And rumors have been floating around that there might be something in development at the Mayo that can tell, okay, are these amyloidogenic light chains or are they just nothing?
Well, actually at Mayo, we're not developing the stabilities like BU. There's some work, Scripps, there's some work about the actual, testing the light chains themselves. So I don't know if Vishali's on, but she might be able to mention something along those lines. I mean, the problem with the free light chain assay is there's a tremendous drift that we're seeing, especially, these kappa patients. There's been kappa drift with the binding site assay. They keep saying they're going to correct it. They have corrected it, but everybody is seeing a lot of light chain MGUS. And so we just submitted a paper sort of looking, especially for the ATTRs, an algorithm. Some of my Maz Hannah is one of the people who says, I can't stand these damn light chains, in the TTR setting. And so we sort of tried to do some partitioning, data modeling to see like when can you disregard it, at least in the TTR. But for the light chain MGUS patients, we're also working on something there to try to get a clinical sensitivity specificity thing because it's problematic. But there may be, more functional tests. There's the C. elegans model in Italy. There's, things were in zebrafish looking at toxicity. But the biggest was Jeff Kelly's group. And then one of the collaborators went to BU where they're looking at some stability stuff. So is Vishali there anywhere? I saw her earlier. I guess she left.
Yeah, she was. I did see her logged in before.
The other thing that we see is like glycosylation on the mass spec, but that's not a stability thing. So that's a characterization that if you see glycosylation, the risk is like about 10-fold that this patient's going to have amyloid or something like that, but not like a specific test.
Thank you. I think we're all anxiously awaiting some way to determine what the difference is between real light chain MGUS should it be and what's just garbage.
There's the past at least 8 years, there's been a lot of garbage, and it's a problem. And it's going to get even more confusing, you know, if Siemens, you know, starts coming on board, everything's going to be confusing. And their price point, at least in Europe, is less than what the binding site assay is. And so, you know, like unbeknownst to you, you know,
Yeah.
your laboratorian is going to all of a sudden this like different assay, and it's like, what the heck is this number? I don't recognize this reference range. And
Yeah, that's gonna make all of our lives so much
more
easier.
interesting.
Yeah.
Witteles, I've got a question for you that's come up a few times, and I see it from referring docs and colleagues as well, which is, you know, some of these patients with amyloidosis, particularly ATTR, can have fluctuating ejection fractions, and we'll talk more tomorrow about the difficulties of assessing that sometimes. But you do see some patients with a low ejection fraction who do have potential blood pressure room. You know, maybe they're not hypertensive, but they are kind of normotensive, where someone with low ejection fraction, you would want to push their neurohormonal blockade. Is that something you try to do in patients with amyloidosis with a normal blood pressure, or just go with the concept that really not much neurohormonal blockade is going to help these people and actually may make them feel worse?
Yeah, I mean, I think the biggest thing to take away is that ejection fraction is just a horrible marker in this disease, and really in restrictive cardiomyopathies in general. You know, it's useful when you're talking about big cavities. It's not, you know, the ejection fraction of a tiny cavity can look very different and can mean a difference of measurement of 5 cc's of stroke volume. It's just not terribly relevant a lot of the time. To directly answer your question, the biggest thing I would say is I would never be pushing goal-directed medical therapy and sort of pushing the envelope as you and I might in a typical dilated cardiomyopathy patient, where you're going to say, yeah, we're going to keep pushing ahead with relatively low blood pressures to get them on it. So no, I don't tend to push it. If they're frankly hypertensive, sure, I'll treat that. And if they're normotensive without any postural symptoms and they already came on these agents, particularly RAS inhibitors, I won't proactively take them away. But it should not be the focus of the care of these patients.
And I'm going to throw something in. Certainly, I think there's a big difference between an AL and an ATTR. I mean, I think ATTRs can tolerate a little beta blocker way better than the ALs. And
Totally agree. I mean, the ALs, I would actively take them away almost all the time. In fact, it's often diagnostic that they have AL because somebody's given them an agent and they've passed out because of A, their hearts tend to be iller, and then B, the autonomic dysfunction and often the proteinuria that they'll have as well.
And they need that rate. I mean, they just, yeah.
So, Ron, when do you use carvedilol if you use it?
In all my non-amyloidosis patients.
Yeah,
Use plenty of
okay.
it, but not in no, I mean, in the amyloidosis patients, I would say I just about never, because if I'm using a beta blocker, it's usually for rate control, and there's better rate controlling beta blockers.
It's not unusual to see patients on a low dose of metoprolol if they've had you know, non-sustained runs of VTAC, 8-beat runs, that sort of thing. Do you have a view on that use?
Yeah, and this is anecdotal again. I don't think there's any good evidence on this. I don't particularly think that, I mean, for the AL patients in particular who tolerate beta blockers in general so poorly, I tend to think you lose more than you gain from it. And I more would think about the VT as an indication for a defibrillator than I would for beta blockers. Again, I think the TTR patients, you know, as was pointed out, are clearly behave differently. And but I don't tend to use it for VT. When I use beta blockers in amyloidosis patients, it's almost always for rate control of atrial arrhythmias.
All right. Well, it is 3 o'clock, and unfortunately, we would love to keep going, but we probably need to put in a plug for tomorrow and then send on any questions that we weren't able to address directly to our speakers. So thank you again, Drs. Comenzo, Dispenzieri, and Dr. Witteles for speaking today. This has been a fantastic discussion. I feel like we've all learned quite a bit. So I'll just plug tomorrow. It is multimodality imaging day. So that will again be from 2 to 4 p.m. Eastern. 1 to 3 p.m. Central. And we will have 3 speakers, Dr. Ibrahim Mila Dorbala and Mariana Fontana, speaking to us tomorrow on imaging. So thanks again, everybody. Have a great afternoon.